So this is time for Ask the Experts session. This is one of the most appreciated sessions of our community conferences. And Dr. Ed Less, who is a Chordoma patient himself, but he is a member of our community advisory board and has done many other wonderful things for the foundation. He's the medical liaison on the community advisory board, so he kind of works in between the CAB and the medical advisory board. So he's here to be our moderator for this session and ask questions. We'll start with some pre-prepared questions and then take some live questions from the audience, and we'll be running around with the mics so that we can capture all that on video. Welcome in. Oh, I had something else to say. There's two changes in the lineup of the experts. We have Dr. Yen-Lin Chen from Mass General joining us in place of Dr. Josh Shibata, and you already know Chris Heery, who is here in place of Dr. Greg Cote.
Thank you, Shannon. Good morning, everybody. Where did Bill go? Bill, you in the room? Or, somewhere. Anyway, I wanted to make some comment about Bill's remark about sirens. You know, I had a bit of a misspent youth, unlike Bill. So when I hear sirens, I think somebody else is coming for me. It's not the ambulance. Okay, I turned 50 this year, so now I officially get to wear my spectacles for this sort of thing. I want to thank our panel. We have, so Chris here you've met already. We also have two neurosurgeons, Dr. Hornacek and Dr. Gardner. A little wave of the hand.
That's right.
Pardon?
Dr. Gokaslan, rather than Dr. Hornacek.
Yeah, where's Dr. Hornacek? He's not here.
I don't know.
I thought we had Dr. Hornacek on the panel. Sorry about that.
Me too, man.
Dr. Gokaslan, Chief of Neurosurgery at Rhode Island Hospital. Paul Gardner's from University of Pittsburgh, skull-based neurosurgery program there. And we have Dr. Tom DeLaney, who is familiar to many of us, a longtime director of Proton Beam Center here in Boston, and Dr. Yen-Lin Chen, also from Mass General, also a radiation oncologist, Dr. Patel, medical oncologist at MD Anderson, and who I met, Dr. Adrienne Flanagan from the UK, who is a clinical pathologist, and she told me yesterday that she is not moderatable, so I'm not sure how that's going to play out. It looks like Trumpism has jumped the ocean. Sorry, I had to say one thing about Donald Trump. I've heard nothing about him for days. It's been so refreshing. So just before we get started, I have to say, Josh, wherever you are, that I'm a little bit surprised to get invited back. He doesn't know this. Last year, or 2 years ago, I mean, in Boston, I moderated the same panel. And I don't think anybody noticed, but so I came down for breakfast, just like today, and had a cup of coffee, and then I settled into my seat in the back where I usually hang out, and I had a few minutes, and I realized that I had forgotten to take my morning dose of Synthroid. You know, Synthroid for those of us who have low thyroid activity. So I thought, well, you know, I got a few minutes, I'll pop upstairs and just take my Synthroid and then come down and we'll just get started. So I went upstairs to my room, 20 or 25 floors up, and barged into my hotel room and rummaged around in my toiletry bag, which usually just kind of packed in haste. I have 4 kids. My life is chaos most of the time. So I just sort of stuffed stuff in there. So I pulled out the vial and unscrewed it, took a tablet and stuck the vial on the counter, came downstairs, sat myself back down. And the first talk started, and I started to feel odd, and I fell asleep, and I woke up approximately 75 minutes later with drool on my shirt and this funny metallic taste in my mouth, and it began to dawn on me with a growing sense of absolute horror that maybe I had screwed up. I went back up to my hotel room, and in my toiletry bag, I didn't even intend to pack this stuff, but you know, emergency doctors like myself, we use this sleep medicine called Imivane or Zopiclone, which is like a heavy hitter sleep drug to help us sleep in between short shifts and so on. And so I'd taken this drug, which has onset about 30 minutes, maximal impact, 2 hours, which coincided nicely with when I was supposed to moderate this panel. And it was too late to make myself throw up. The stuff was already in my system, and it's not like I could pump my own stomach. I mean, the concierge here is awesome, but I don't think they'll do that for me either. I stumbled out onto the street to look for somebody who would sell me some uppers, but I'm in the wrong part of town. I was screwed. So I drank about 17 cups of coffee and managed to blunder my way up here and somehow got through it. Has anybody watched the movie Zootopia? If you haven't watched it, just watch the trailer and you'll get a pretty good sense of how it went, because the sloths are featured prominently and they move at approximately half speed. And that's the way I sounded. I'll just write around words. Anyway, all right. Enough preamble. So the way it works is that we'll do the prepared questions first, and I'll jump around a little bit. If anybody feels left out on the panel, just sing out. And then we'll try to leave 30 or 40 minutes toward the end for questions from the floor. So first question for doctors, for the neurosurgeons, Dr. Gardner, Dr. Gokaslan, and also for the radiation oncologists. Maybe we'll start with Dr. Gardner over there at the end. When is surgery alone with no radiation recommended for an initial diagnosis?
Sorry, can you just repeat one more time?
Yep. When is surgery alone with no radiation recommended with an initial diagnosis?
That's a tough question. I don't think that there is a solid answer to. I think that there are a small percentage of tumors that are usually found incidentally, probably before they've become particularly active, that can have a wide resection, so not only the tumor, but also some normal tissue around them. And certainly in the skull base, it's different what you can achieve than in the spine. In the skull base, we usually end up shelling out a tumor and then trying to remove tissue around it because of the critical structures. Where in the spine, they try to take it out as one piece. So in some of those situations where perhaps the tumor is less aggressive, then radiation maybe could be avoided. But that's unfortunately not been very well studied. We actually recently just finished looking at 105 patients with purely clival chordomas, so skull-based chordomas, which do seem to be different than spine chordomas as far as their DNA, and found that there are certain markers that predict how aggressive tumors will be. And we found somewhere around 17% of those tumors that maybe could avoid radiation if they had this kind of wide resection. So it's a small percentage, and I think we're still trying to learn which tumors those are, but I do think they exist. I think the question is how can we better characterize them, and we're just starting to get a handle of that, at least in the clivus.
Just to follow up on Dr. Gardner's point here is that we do believe that the tumors that are located in the skull base versus that those are located in the spine and particularly in the sacrum, they are probably somewhat different tumors biologically. And from a surgical perspective, in the skull base, it's essentially technically impossible to remove the tumor in one piece, and hence the resection involves getting most of the or all of the tumor out in an intralesional fashion from inside out. Whereas in many circumstances in the spine and the sacrum, the tumor can be removed in one piece, although the margins can sometimes be very thin on the areas where it's close to the spinal cord. And so there are situations where if we have gotten the tumor out in one piece and we have healthy tissue around the tumor all along, and the margins are not compromised, there are circumstances that we may want to avoid the radiation therapy. Having said that, I think Chris made the point previously that even in situations where we remove the tumor completely, there might be skip lesions beyond where we excise, and the tumor can come back at a later time. And so we always consult with our radiation oncologists and they get their thoughts whether or not additional radiation therapy would be appropriate. In many situations, they would recommend additional therapy. In other situations, they may elect not to and reserve that for a recurrence at a later time.
Thank you. Go ahead.
I think that would be one possible item for future research would be to try to pick out patients up front who would not need radiation, particularly for the sacral lesions. As Dr. Gokaslan mentioned, pathologic studies for sacral tumors show that about 40% of patients will have tumor implants beyond the gross tumor that you can see. And these are often up to 2 centimeters beyond the tumor. I think if we could predict patients who have those up front, those would be patients who we would want to do radiation prior to surgery, because I think those patients probably have a higher rate of tumor that gets further disseminated by the surgical procedure. The data from the Mayo Clinic does suggest that there are patients, if they have a wide resection, will do well without radiation. And those are usually patients who have in the very lower part of the sacrum or the coccyx. But I think if you can't predict correctly, if you do the surgical procedure, you're often left with a situation where there's a lot of bowel in the field. It's harder to radiate. And I think the reality is if a patient has a local recurrence, most studies show they have a higher rate of metastatic disease. So I think we want to try to do everything to control the tumor at the initial treatment, and then it really gets to, for the physicians and the patients to weigh the risk of a recurrence versus the morbidity of the radiation treatment, which again, it really, I think, depends on the size of the tumor, the location, the technique that's used.
Sure. Dr. Patel.
I think that the take-home message from the discussion here should be that both the surgeons and the radiation oncologists should really be involved in the decision-making, and then they need to make that decision jointly. There's definitely an advantage to radiation therapy if you're able to administer it in addition to the surgical resection, and I do agree with Dr. DeLaney that probably long-term recurrence rate would be lower if you were to administer the radiation therapy. On the other hand, there are also concerns with the radiation therapy that there are side effects associated with that and so forth. I think that those decisions should really be made jointly, and if the decision is to proceed with radiation therapy by our radiation oncologists, we would follow their recommendations. But there are circumstances if we feel that the tumor has been removed in one piece and that the margins are negative, it's perfectly, at least in my view, reasonable to follow the patient for a period of time and see if they would develop a local recurrence, and thus avoiding the potential downside of the radiation therapy.
Just one final comment, if I may. Supporting the notion that there is no one right answer to this question, throughout this meeting we heard 2 proposals of clinical trials. There is a AO North America Tumor Forum sponsored trial where there will be several arms based on the experience and expertise of the team as to how to manage that primary tumor patient, and hopefully a couple of years down the line we may have some comparative answer. And Dr. Radelli from Milan presented the SACRO trial where there will be surgery, radiation based on choice of the patient or physician. And then there is a randomized arm to either go surgery or radiation if that was feasible, acceptable. So until we get some of this information, I don't think there is a clear-cut answer as to is surgery the standard, is radiation the standard, and when exactly would be used combination. But I think the experts, based on their experience, will make the best decision for a patient that's in front of them.
Thank you. Dr. Chen, you have a comment too?
Yeah, just a comment on in terms of salvaging when a tumor is recurrent, and it really depends on where, what type of recurrence you see. If you do see still very localized recurrence, it may be possible to salvage, but seeding is a far greater concern. And so there are some upfront risk factors, such as extraosseous extension into the surrounding muscles, and or prior trauma, fracture to the area. And there's also a very small percent of patients with lymph node involvement, which we recently reported. So there are some risk factors that you can consider up front as far as the
Thank you.
recurrence.
Okay, let's do another question. This one we'll direct toward, maybe for starters, to Dr. Flanagan. We know that there are subtypes of chordoma: conventional, poorly differentiated, dedifferentiated, and in addition to being classified as one of these subtypes, are chordomas graded or staged in any way?
That seems more than one question.
It's kind of more than one question, yeah. Do you want me to repeat it?
Yeah,
So-
ask me the first one.
Well, essentially, it essentially just lays out the subtypes of chordoma that we know, conventional and poorly differentiated, dedifferentiated. And the question is, are there other subtypes of chordoma or other ways in which chordoma is staged, like more traditional cancers are?
Okay, so when the pathologist looks down the microscope, frequently the picture that they see is very typical, and they're able to say that's a chordoma. But there is a bit of a difference. Some of them are bigger cells, some of them are smaller cells, some of them have more jelly-like material, some have less. But it's pretty typical in most cases. And then there is a minority of cases which that's called the conventional or the classical form. And the second type then, which we're very happy to call, is the dedifferentiated form, which means that if you look at that down the microscope, you can't call it a chordoma. It looks like anything. It could be any kind of bone tumor. It could be a brain tumor. You cannot classify it. You can only call it a chordoma because adjacent to it, there will be the conventional or the classical component. And it's only with that component can you call it dedifferentiated. Does that make sense? So you've got classical and something happens that makes it go weird and it turns into this tumor that doesn't look like a chordoma at all, and it doesn't express brachyury. So that's the dedifferentiated type. Fortunately, it's uncommon, and it has a poorer prognosis. Sometimes, more commonly, that occurs later on in the disease when it recurs. So you're very unlucky. Well, you're very unlucky if you get chordoma at all. If you get it dedifferentiated, you're even more unlucky. But it usually occurs when it does later on in the disease. And then in the middle of that, you also have what is called a poorly differentiated chordoma. And there is no agreed description by pathologists as to what that really means. And it's become very fudged. So there is a very small group of chordomas called poorly differentiated chordomas, which usually occur in children, and they have a slightly different genetic alteration, and it's called INI1. It's called other things too, but let's call it INI1, and it loses the expression of that gene. It's usually in children. It's probably only less than 5%, and it usually occurs in the base of the skull or at the top of the neck. Those patients, we call it chordoma. They don't look like the classical chordoma, mostly, but it's really classified by the absence of that gene known as INI1, okay? So in a way, we shouldn't call that poorly differentiated. We should call it an INI1 negative tumor, because some of those patients can go on to a clinical trial. The more we learn about that, the better, okay? And then there is another term which is a rag bag, which is called poorly differentiated. And it still has INI1 expression. But you look down and it looks like a chordoma, but it's a bit more weird than your normal chordoma, but it's not dedifferentiated, okay? So there's a kind of a full spectrum, and that's what poorly differentiated is. And we think that if it's poorly differentiated, you're likely, the prognosis is probably worse. But these numbers, it's very subjective. So, and there aren't good outcomes as to whether patients with that phenotype, meaning its picture, do better or worse. So to recap, most of them are conventional or classical. A very small minority are dedifferentiated, which don't express brachyury. Then you have the ones which usually occur in children, which are better classified as the INI1 negative chordomas. And then we have this other rag bag called poorly differentiated, but actually it's really a very subjective term used by pathologists. So I suspect that is now as clear as mud to most of you.
Could I ask you, as someone who's not a pathologist,
Okay.
to explain what you mean when you say differentiation in layman's terms, if possible?
Okay, it's possible. So we call, if something is differentiated, it means that cancer or a tumor, it looks like it looks like a normal tissue usually. So if you see breast cancer, it looks largely like what normal breast cancer looks like. If you see colon cancer, so it's differentiated towards that type of normal tissue, okay? So if something is differentiated to skin, it looks like a normal skin, but it's gone a bit awry. So the chordoma arises from what we think is the notochord, which only occurs in the fetus. And so when we say it's differentiated, it looks a bit like the notochord, okay? It's differentiated towards the notochord. So when it's de-differentiated, it no longer looks like the notochord. It's become it doesn't show a picture that you can say whether it looks like brain or skin or toenail or thyroid. It doesn't look like anything. That's de-differentiated.
That's thought to be based on mutations. You know, the tumor looks a certain way because of its DNA, and as sometimes tumors over time pick up mutations. And so as they become more mutated, sometimes they can shift, correct me if I'm wrong, but they can shift to where they don't even look like themselves anymore because their DNA has changed so much that it's producing something completely different. That's the theory anyway.
That's correct. And in the de-differentiated type, you no longer have brachyury expressed. Brachyury is expressed in the notochord, so it no longer looks like the notochord.
So I'm just going to say like 2 sentences about this because I think this is a really hard concept, and I assume that most of you are thinking, what are you all talking about? And so when a human is first made, you take 2 cells, or 2 half of cells essentially, and you put them together, right? To the genetic components of the 2 parents. And you have to start out with something very primordial, right? It has all of the genetic information available, and none of it.
What does primordial mean? Now you're looking.
All right.
This is what happens. This is why we need patient navigation. This is what happens when physicians try to dumb down their language.
You're starting out with something that has not in any way differentiated.
Primitive.
Yeah, primitive. It's just starting with all the raw data. And then over time, those cells are going to change into something that looks more and more like all these different tissue types. And in cancer, sometimes those programs go backwards. They run in reverse. That can be through mutations, or it can be through transcription factor regulation. And that brings us back to what brachyury does and all of that. But I think it's a tough concept, and don't be daunted if you are confused by what this is. You probably need to hear it about 10, 15 times before it makes a lot of sense. But it is a really important component of how you decide how aggressive those cells might behave, particularly in chordoma.
So related to that, Dr. Heery, so the next question actually is tangentially related to that because it's a question about pediatric chordoma where you more typically or more commonly will see de-differentiated or more immature chordomas. And the question is, for pediatric patients, is it sometimes not possible to be treated by doctors who have experience with both pediatrics and chordoma? I think what they're asking is it's difficult to find a specialist both in chordoma and in pediatrics. Is it more important for such a doctor, surgeon, or medical oncologist to have experience with pediatric tumors or with chordoma specifically? You first. And then, yeah.
Well, I'll say this. The only thing I know about kids is taking care of my kids, right?
Right.
And I do not know how to handle a child as a doctor at all. I don't know how to give them IV fluid. I don't know how to give them the right dose of medications. I don't know any of that stuff because that is what you train and learn as a pediatrician. You cannot treat a child if you haven't been trained to treat children. So I'll just start there. Is it important to know about pediatrics or chordoma if you're going to treat a patient with pediatric chordoma? The answer is yes. You need to have both. If you don't have one person that has both of those things, you need to have 2 people who are good at talking to each other and are willing to work together. I think that's, and what is amazing to me about surgeons and radiation oncologists is that they have to learn how to do both. I don't know how. It is. Children are not little adults. They are totally different in how they respond to therapies. They can deal with fevers that an adult would almost die from. So it is a totally different experience dealing with a child, and I have never done it. So if you came to me and said, can you treat my son or daughter, and they're 11, maybe, right? But if they're 6, no chance. I would not know what to do, and I would probably hurt that kid more than I'd want to help them. So,
Dr. Chen, from a radiation oncologist standpoint, what's your take on this issue?
Yeah, I think having expertise and experience in chordoma is important, but no one works alone. I think, so Dr. Norbert Liesch, who is not here, actually has the most experience of anyone with pediatric chordomas in radiation oncology. And he's extremely good at working with teams, so getting the right surgeons involved, in where the surgery takes place is also important. You with the right surgeons involved, then you've got to have the right recovery team and to support the child. So maybe a pediatric ICU, neuro ICU would be more appropriate. And then having a radiation oncologist with knowledge about the normal tissue sensitivity to radiation and using the right modalities. Protons, for example, to limit the dose to brain, up in the base of skull or lower in the mobile spine. Lots of growing tissue that needs to be considered. So I think it is important to have both, but you may not find that in one particular person
Right.
unless you clone Dr. Liesch, and a lot of us tried to learn from him. But it is important to work with a team
Right.
that bring different expertise to the table.
Dr. Gokaslan, from a surgical standpoint, do you run into this issue from time to time? You must, from referring centers, a younger person, a child with chordoma?
Definitely. I think Chris nailed it. I think if you choose either purely a pediatric surgeon or purely an adult chordoma surgeon, you are going to not get good treatment. And there's no answer to your question. There is not one or the other that you could choose. You have to find a team that works together. When we do pediatric chordomas, we do the surgery, we add a team member, and that team member is a pediatric neurosurgeon, because there are things they know about pediatric neurosurgery during surgery, before, after, all of those aspects that we would never be able to provide, and that child would not do as well in some situations without that. Conversely, if they try to purely manage this themselves without someone who is familiar with some of the anatomy and some of the aspects of chordoma, it would be a lesser surgery. So there just is no solution. Even Dr. Liesch, I'm sure, uses pediatricians as part of his team to take care of those children. And so that concept is it does require team surgery, 100%, just like the treatment requires a team, not just of surgeons.
Right.
I'm fully in agreement with Dr. Gardner here, and I do operate occasionally on pediatric chordoma patients, and in all of those cases, we would have one of our pediatric surgeons to be a co-surgeon with me in the OR, and the patient goes to the pediatric intensive care unit, and they have special needs, and I am not really the best person to provide that care to the patient in that environment. So we have to take advantage of the resources that are available to us around us to provide the best care for the child, and you have to have a team of physicians caring for the patient.
I think the test question that helps you resolve the mystery that many of you ask, I tell patients that they should ask, is when the diagnosis is being discussed with the patient or the parents in this instance, asking the provider or the physician, have you dealt with this before? Have you seen this before? Do you treat this? I think that gives you the answer. That is, the good pediatrician will say, no, I'm not capable of this, but I will help you find somebody and work with the chordoma expert and will take care of it. And if you found a chordoma expert, they will say, well, I do treat chordomas, I know what to do, but I don't deal with pediatrics, so let me find a partner to help with the pediatrics part of the management. And so at the end of the day, you're going to need both, but the question that is being raised will get answered if the starting person has some level of expertise and experience. And if you hear, oh, I do bone marrow transplants as an outpatient, I can handle anything, you quickly need to find somebody else.
Exactly. Thank you. A couple of radiation questions, perhaps quickly. Dr. DeLaney, proton beam therapy is not available to all patients or in every country. In these situations, how should it be determined what type of photon radiation is recommended? For example, IMRT versus gamma knife.
So again, the difference between the different kinds of radiation, the photon or X-ray has been the conventional radiation treatment for cancer patients for many years. The difference between X-ray or photon and proton is that protons go a certain distance in the patient and then stop. So they can reduce the normal tissue radiation dose by up to 50 to 60%. There are currently randomized studies comparing X-rays and protons for low-grade brain tumors, head and neck cancers, lung cancer, esophageal cancer, primary liver cancers, lung cancer. So I think down the road we'll have comparative data. For pediatric patients, I think there's a huge advantage for the use of protons because you can eliminate the exit dose to normal tissue, and normal tissue that's growing can be adversely affected by radiation. There are an increasing number of proton centers. In 2002, there were 2 in this country. There are now 25 and another 11 under construction. Another question that's frequently asked is about carbon ion compared to protons. So protons and carbon ion are both charged particles. They go a certain distance and stop in the patient. So both of them reduce the amount of normal tissue radiation dose. Carbon ion is 12 times heavier and has 6 times the charge of a proton. So it has a somewhat higher physical energy deposition at the end of its range. But although there are some physical and biologic differences, the clinical data seem very comparable for protons and carbon ions. And there is a randomized study being conducted in Heidelberg, Germany, for both skull-based tumors and for chordomas, where patients are randomized to either protons or carbon ions. So that question is being asked. Some of the other alternatives that you may hear are what's called IMRT, that's intensity modulated radiation therapy. So those are it's an X-ray treatment, and it basically is the flip side of a CAT scan. A CAT scan is just a map of radiation dose absorption. If you drive that process in reverse and you draw the map of radiation absorption that you want, with a lot of radiation being absorbed by the tumor and less by normal tissue, you put in variable packets of X-rays from different directions, and you get a very nice conformal radiation dose. And you can often achieve similar doses to the tumor with IMRT as you can with protons, but you get, as I say, the total body radiation dose is about twice as high. I think the biggest advantage for protons is that younger patients, also the larger the tumor, the larger the advantage for protons. If you have a large tumor, you get a lot of exit dose beyond it with X-rays, which you eliminate with protons.
Sure.
Some other techniques that have been used are what people refer to as stereotactic body radiation, which is, again, is often a single radiation treatment. This was developed initially, at least in the context of lesions in the bone, primarily for patients with metastatic cancer. Treat a single fraction of radiation, and it was designed to completely destroy the tumor that was being treated, which is an excellent treatment provided you can spare the normal tissue. So this is used, for example, in tumors in the liver, for example, primary lung cancers, because there's a small margin of normal tissue around the tumor which is going to be completely destroyed. In the context of many chordomas, that can be an issue with cranial nerves, spinal cord, skull base nearby. And you can do it. The Memorial has used 2,400 rads in a single fraction. But it can be a very unforgiving schedule because if there's any normal tissue there nearby, there's a risk if it exceeds the normal tissue tolerances. And there are safe normal tissue tolerances, but if, for example, you aren't aware that there's some esophagus in front of a vertebral body you treat, you can have a esophageal injury.
Right, thank you. Dr. Chen, at the 2016 conference here, there was a question asked about pre and post-surgical radiation. You weren't part of the panel then. Would you be able to tell us what the current status is with respect to that technique, what the rationale is for that?
Mm-hmm. So we, as an institution, have used preoperative radiation for a long time. Dr. Herman Soot began using this based on the observation that you can indeed see seeding or contamination of the surgical field in situations where the tumor may not have been removed completely, and that if you use as low as even 2 weeks of radiation, and he actually extrapolated the data from bladder cancer where patients with removal of whole bladder could still develop seeding in the incision, that doses as low as 3 gray times 3 or 20 gray in 10 fractions, or we use 19.8 and 11. Basically, low doses can pretty much reduce that risk of seeding to really nothing. And so that was used for a long time, for several decades, as our approach with 19.8 gray pre-op, and patients could go for surgery right away, and then upon recovery receive the remainder of the radiation dose. And what we've learned is it is important that cumulatively that you reach a certain dose level to achieve the best chance of local control. And then we have analyzed patients who are treated with preoperative radiation followed by surgery and completing the rest of the radiation versus patients who start with surgery and then receive an adequate dose of radiation. And in both situations, even if the radiation is still designed the most optimally as far as what it's covering, there still appears to be a difference of about 20-30% in local control between using some form of pre-op radiation versus surgery first, followed by planned radiation. And so I do think if possible, we do recommend using preoperative radiation. Our current strategy is actually, and this is more commonly used now, is to use a higher dose of preoperative radiation. We use 50.4 gray, or basically about 5.5 weeks of radiation first. This would need to be followed by a longer period of recovery, so typically about a month before the actual surgery. And then the remainder of radiation is given, and that typically would take somewhere around 8 to up to maybe 13 days, depending on the surgical margin, to just complete that dose of radiation. And that's dependent on the margin. But the rationale for that, for the switch to that, is if you give radiation postoperatively, a lot of the small bowel, as Dr. DeLaney alluded to, may have moved into the area, and small bowel can become fixed in the tumor bed, and it's undesirable in a lot of situations to give 5 weeks of radiation to that bowel that's next to the tumor bed that you want to treat. And we also observed that if you give, even with 20 gray of radiation, there can be some delay in wound healing. And so why not actually plan for a better plastic surgery involvement, for example, or better flap closure, so better wound closure, but give most of your therapeutic dose up front. And so we have switched our strategy to giving this higher dose preoperative radiation, and the day before we reported our results that if you give higher dose pre-op radiation, the wound healing complication rate is the same. There's no difference. And there appears to be a higher rate of being able to achieve a negative margin, no viable tumor at the margin, so a more complete resection. And there is a trend towards better local control for patients receiving the higher dose pre-op.
So just to be clear, this pre and post-op radiation technique applies only to chordomas of the mobile spine. We're not talking skull base.
That is correct, yeah, in the mobile spine, right.
It's not done
in the
at all with
skull
skull-base tumor.
Right, I think the concern is the wound healing issues in the skull base would be that much more significant, CSF leak and such.
Sorry. Yeah. I just wanted to try to clarify and also ask Dr. DeLaney one question. I think probably all of us who treat chordoma try to get everyone to proton beam as the form of radiation for two reasons, the reasons Dr. DeLaney discussed, but also the expertise of people who have treated chordoma. And I don't think that can be overemphasized. And I guess, probably if someone absolutely cannot get, for social reasons or financial reasons, to proton beam, first of all, most of those centers have assistance for people, and there are ways to manage that. But if they absolutely can't, then probably IMRT would be the preference over stereotactic. Most of us would not recommend stereotactic radiation or radiosurgery for these lesions. But a tough question for you, Dr. Lane, is would it be better for someone to be treated by someone with no chordoma experience who uses a proton beam, or by someone with a lot of chordoma experience who uses IMRT?
Yeah. I think
And
that-
granted,
yeah,
most people with chordoma experience use proton beams, so it's a little bit of a loaded question, but
No, I think the experience with the chordoma is probably the most important. And I think, as Paul mentions, that the treating physician has to make a decision, one, about what volume has to be treated with these techniques, particularly when you're using high doses. You have to be very judicious in where the tumor is, that you include the areas at risk, that the areas at risk receive adequate dose, and at the same time you spare the adjacent normal tissues. There's a report using stereotactic IMRT for skull-based chordomas from Toronto, where they have, the radiation dose isn't quite as high, so the results aren't quite as good as you'd expect with protons, but they're quite good results. And that center there, the individuals are quite experienced. So I think it's really important to seek someone who's experienced with the disease.
That's essentially why the province of Ontario has stopped funding Ontario patients to come south of the border for proton therapy because of those results.
If I may add one point here is that from a surgical planning perspective, it's also very important to be working with a very experienced radiation oncologist. Sometimes if we are not going to be able to remove the tumor completely and we are trying to achieve gross total resection of the mass, it's very critical to clear the tumor around the spinal cord enough in a circumferential fashion that our radiation oncology team can administer very high doses of radiation to the target. Most of the time, if the tumor is making contact with the spinal cord, in that area, the dose needs to be adjusted, downgraded, and hence we tend to get recurrences. And again, that goes back to the comment that Dr. Gardner made here, is that it's much more important, at least in my view, to be working with a radiation oncologist who has got a lot of experience in treating chordomas, because the planning of the treatment is much more complex than most other standard types of radiation.
Okay, thank you. I have a question. Maybe I'll start with Dr. Flanagan. I'm not sure to whom we should go. So the question is, it relates to previous injury. Have any studies been conducted to see if injuries or breaks to the coccyx sacral area could contribute to lesions that form and their growth, or have adult clival patients suffered previous injury to neck, like whiplash and sprains, etc.? Is that a risk factor for the formation and development of chordoma? Do we know?
I'll be brief.
Yes.
I think that the answer is no.
Okay, we're done. That's brief. Go ahead, I'm sorry.
We'd have all the Boston Bruins in here.
Yeah.
I mean, I will be brief, but every time somebody turns up, or almost turns up with an osteosarcoma, which is another rare tumor, but not as rare as chordoma, somebody can always remember they fell off their bike, they broke their leg, they had a football injury. It's too much of a coincidence, I think, and I think the answer is no.
It's probably vaccines. Doctor, sorry, go ahead, Chris.
Please don't even make that joke.
Sorry. Dr. Patel. Again, this is a more general question, but I'll just start with you. It appears that we are hearing more and more about people diagnosed with chordoma. Is the 1 in a million statistic that we always hear still valid, or is there an increase in chordoma, or is this due to better diagnostics or something else? What do you think?
I think that the incidence is stable. Certainly in the UK, where we have national statistics, and I presume we have the same in the US, and we monitor it, there is no increase in the diagnosis, in the incidence of chordoma.
Sure.
I agree.
There you go. I'll pick on you again, Dr. Patel.
Well done.
Can chordoma patients donate blood or donate organs? Dr. Patel. Down.
So my answer would be yes, but I think it depends on where in the natural history of chordoma are we talking about. And more importantly, I think the organ donation and blood donation ability is controlled and restricted by federal and national guidelines. So sometimes they lump malignancies together. That is, if there is a prior history of cancer, you cannot do these things. Well, and by definition, we can't call chordoma a benign tumor. It is a malignancy. So I think it is the guidelines that may be restrictive in terms of one's ability to do it, but technically, for those folks who have been far enough out and are potentially cured from the disease, there should be no medical or theoretical reason to do it. There could be other political reasons that we can't control.
I think that's right. I think there are other political reasons that are more of a hurdle than anything else in most institutions. Dr. Heery, when is it suggested that chordoma patients seek molecular profiling tests of their tumor cells?
It is not officially recommended at all. I said this in the last session. There is no downside to doing it, but be cautious how you interpret the results of those tests. I would strongly encourage that if you'd like to have molecular profiling, to do it as part of some organized trial, either in a database capacity for accumulating data on the molecular profiling of chordoma as a population and trying to understand what those subgroups do in terms of progression, time of growth of the tumor, overall survival, because otherwise this very valuable data that you might get will sit on the piece of paper that you received and no one will know what to do with it. So please consider getting it done as part of a trial or a database collection method. However, I don't want you to be disappointed when you find out that that information may not help you personally. And that is not just the state of affairs for chordoma, that is the state of things in almost all cancers today. There are some very specific things that we know in very specific tumors that result in choosing medicines that are very, very effective. But I can count those things on my two hands.
So the corollary to that, for example, so if you find a target and you rejoice because you have the target and there's a drug for that target, it does not mean that your cancer is going to stop growing.
No, and
necessarily.
I use this example probably far too often, but we're here, so I'll use it again. There is a specific mutation that's found in melanoma. It's a very specific point mutation. And if you have that mutation, there are drugs that work very effectively to shrink your cancer. Not forever, and it doesn't cure that cancer, but it works, and we know it works for the vast majority of patients that get the drug. You take that exact same mutation and the exact same gene in colon cancer and give those patients the exact same drug, and it doesn't work, okay? And that is the caveat I try to, it matters whether the gene that you're looking at is the thing that makes the cancer go when you hit it. And it seems that that gene isn't the thing that makes the cancer go in colon cancer, and it is the thing that makes melanoma go, right? Or at least some percentage of the cells in that tumor. And it's hard when you hope that one of those things is going to work, and sometimes it does. And what we end up with a lot is the anecdotes. We hear a lot about, well, I had my profile done, and then I got that drug, and it worked. But most drugs are a lot dirtier than we like to think that they are. They say they hit a target, and they actually hit 20. And sometimes a drug works, and we thought we were hitting a target, and we were actually wrong about what the target was that the drug was hitting in that situation. So I know that that sounds like I'm being a pessimist. I'm not. What I'm trying to get, I hope, across is that these things only result in real solutions when we collect large data sets. And for chordoma, that is a very difficult task. And so I beg you that if you're going to get that done, try to do it through, talk to Patty, see if there's some way that your data can be collected in a meaningful way so that it adds to the total understanding, and that maybe we'll, in a year or 2 or 3, be able to relate that back directly to you. But as of today, there is no official information I could give you, or even not even official.
I
There's
think
no information.
even a little more concrete, correct me if I'm wrong about this, but, for example, Foundation One is something that a lot of people hear about, it's very popular, and that sort of gives you this broad range of what could possibly be targeted in your tumor. But as Chris said, that doesn't have anything to do necessarily with what might control chordoma. And currently now there are, I believe, either on the horizon or immediately available 7 clinical trials for chordoma that have been much more directly thought to perhaps be targeted. It would make far more sense to look at those trials' potential than to do something like Foundation One. Would you agree with that? Or
Absolutely. I'll just point out one other thing about, and this is not an attack on Foundation One.
At all, no.
At all. But all of the companies that work in this space, they have the same broad goal, but they all have to select a panel of targets that they're going to check. You can't check everything all the time. It would be logistically very difficult. You need a lot more sample than most people can provide. So if you look in the panel from Foundation One, guess what it doesn't include? Brachyury, right? So you see the relevance of the test that you do is directly related to the data you get out of it, right? And if you do a test that isn't relevant to your tumor, you get data that is not necessarily relevant to your tumor. And so what we would like eventually is, if we think about molecular profiling in chordoma, is that the very smart people like Dr. Flanagan who are identifying these pathways, that we would make a molecular profiling test that is relative to chordoma, and that everyone would get that test. And that's work that takes years, and it's work that's been ongoing for years. And I think we're getting closer to identifying what those things are. But you might wonder, what is all that work that goes on with cell lines and taking apart tumors? That's what you are trying to figure out. And once you have it, now you can take, a patient who walks in the door and say, do you have these 3 things, and what's your risk, and what treatment might make the most sense for you? But it's a stepwise process. We can't jump ahead in that process.
That's awesome. That's a healthy dose of realism, not pessimism, but realism, I think. One last question about radiation, and then we'll open up the floor and just take general questions from anyone who feels compelled to ask something of our panel. So just amalgamating a couple of different things here, but in general, there's some concern about frequency of radiation scanning, and now with the new recommendations for recurrent chordoma, where you recommend whole body CT and full spinal MR. Are there any concerns with cumulative radiation effect, radiation damage with the frequency of scanning that is now recommended? I'll start with you, Dr. DeLaney.
The general rule for the use of radiation for any medical procedure is what's called ALARA, as low as reasonably achievable. And when you look at the imaging for chordoma patients, at least our practice has been for follow-up surveillance of the lungs. We image twice a year, and we alternate a chest X-ray with a chest CT. In terms of putting that in perspective, a chest CT has 1 rad. When you treat chordoma, you treat with about 7,000 rads. Now that's the area that receives 1 rad with a chest CT is much bigger than the area that receives 7,000 rads with a chordoma. A chest X-ray has about 1/10 the radiation dose of a CAT scan. But it has about 1/10 of the information. It has much less information. But most chordoma metastases grow quite slowly. So I've rarely have, at least in patients we're just doing surveillance imaging, have done CAT scans more than once a year. And after 5 years, we switched to chest X-rays alone. There is interest, and I know in the pediatric population, in doing lung MRIs, and I think that will probably improve over time. There's no radiation with an MRI. So MRIs that are done for looking at the skull or the sacrum or the spine for surveillance, there's no MRI associated, there's no radiation associated with that. But I think currently that the imaging of the lung is still much better with a CT. That being said, there are techniques for, it's called a low-dose CT, where you use lower doses and do fewer sequences. So I think that's the kind of general direction. But in terms of the concern about the radiation effects, the concern is that imaging radiation dose would cause a second tumor. Even in patients who've gotten 6,000 rads for treatment of a cancer, the risk of a radiation-associated malignancy is about 0.5% at 15 years. So if you have 1/7,000th of that dose, it's a vanishingly small risk, and the biggest risk is the risk from the primary chordoma.
Right. You made one comment, just to finish that up, with respect to how you back off on the frequency of chest CT after 5 years, which seems to me a bit upside down, given the fact that the risk of metastasis goes up the further you are out from your primary diagnosis.
It was actually interesting. Most of metastasis, I mean, you can certainly have some delay, but most are actually within, the first couple of years.
Is that right?
Yeah. So, I mean, I think, you can certainly see late recurrences and late metastasis, but overall, uncommon. The key question is, once you do detect that, what can you do with that information? And there are increasingly ablative options available for lung metastasis or, metastasis. But on a CT, you generally can, pick up tumors at like 1.5 centimeter, and that's about the size limit. You can give stereotactic radiation to tumors about 1.5 centimeter with good accuracy. Smaller than that is actually hard to see. So it's a matter of what can you do with that information. So, so in general, we 5 years and beyond, chest X-ray, if something's detectable on that, follow up with chest CT to see something that's treatable.
All right, thank you. Okay, we have 20 or 30 minutes, I think. Shannon? So anyone, there's a couple of microphones, so try to ask your questions at the microphone if you can, so that we can all hear. Thank you.
Hi, so this is mainly for Dr. DeLaney and Dr. Chen. If there's a larger tumor and part of the tumor is in a location where it makes it difficult to radiate, that there might be some structures that would be damaged by the radiation, but a significant part of the tumor is not involved, is there any cases or or have you ever done any radiation on part of a tumor, and would there be any positive results?
Good question. So generally, the concern as far as using pre-op radiation is you want to try to prevent seeding, and the seeding can occur as the tumor is being removed, close to these structures, or it can also develop as a result of, let's say, tumors spillage. And it doesn't happen often, but these are tumors that are not, sometimes are kind of gelatinous, and it can come out in pieces. So if you anticipate that's going to be a problem, where the tumor may not be removed in a complete piece, except for the area where it's contacting that most critical structure, then for most tumors that we give pre-op radiation, we do try to treat the full tumor. And you would, this is one of the rationale as far as how we arrived at the preoperative dose. You essentially want to treat to a dose that those structures can still tolerate, and fortunately, even for margins along dura or margins along the nerve roots, you can use doses up to about 70 gray, and overall neuropathy rate is fairly low. So for nerves that are intact after the surgery, at 5 to 10 years, developing additional neurological problem is at the rate of about 8 to 10%. So it's overall very low. So but if you're treating intact a tumor by itself, you have to go a bit higher than that, and that's when you can run into problems. So in general, we recommend treating the full tumor, and it's not just the obvious tumor, it's actually where these tumors can extend into the surrounding soft tissue or along those critical structures.
One detail about radiation treatment, when we quote a dose, that is really a sort of quick notation for what actually happens. For skull-based tumors, for example, the radiation dose is constrained along the brainstem, so the dose to the tumor is actually heterogeneous, and it's lower along the brainstem. And the reason for this is, from a mathematical modeling point of view, you could ask, well, is it better to treat the whole tumor then to that lower dose, or treat as much as you can to a high dose as possible? It turns out that there's a higher predicted rate of tumor control if you can treat as much of the tumor to as high a dose as possible. And current treatment techniques allow you to paint the dose such that you get the highest possible dose to the tumor, and you constrain the dose on the brainstem or the spinal cord. And there's some interest in even giving portions of the tumor within the tumor where there's just tumor, there's nothing else, a very high dose, for example, it might trigger a greater immune response, and it may be something to look at to be combined with immunotherapy in future studies.
Do you think, though, it would be appropriate to partially treat a tumor, only treat half of it at what you consider an effective dose?
I think the whole tumor should get some dose, and the rationale for giving as much of the tumor as high a dose as possible is after you reach a certain dose threshold, you may say there are 10 tumor cells left. And from a probabilistic point of view, and for the mathematicians in the audience, where's Bill, or the physics guys, it's something called using Poisson statistics, there's some chance that those 10 remaining tumor cells are all going to be in an area that gets the high dose. That's the layman's explanation for the Poisson statistics.
Thank you. Andy.
Ed, two quick questions, if you'd permit me. The first, from our friends Megan and Joe who are watching online. The context of the discussion is that the patient's had a successful first line of treatment and is now asking questions about the ongoing assessment of his condition to avoid or to make certain he's vigilant about checking on the possibility of recurrence. And he asks, are there cases where chordoma has been completely removed and has not returned in the primary location, yet has recurred in a second location? Or I guess it's occurred in a second location.
Yeah, so he asked if there are cases where a tumor's been primarily removed and then didn't recur there but recurred elsewhere. And in my experience, the answer is yes. It is rare, but I have seen it occur. Generally with a little more aggressive tumors is when that is seen, and it's usually, I treat purely skull-based tumors, but I have seen the most common pattern would be it can actually spread down the spine through the veins that come, there's a vein that runs behind the base of the skull down the spine, and I have seen that very rarely, so then it can track down into the cervical spine. There is a recommendation by the Chordoma Foundation to at least do one pan scan of the spine, but again, that's very rare. And it's also, again, with very aggressive tumors. I also have seen one case ever in over 200 cases of skull-based chordoma where it did the opposite. So it was a cervical spine tumor that then occurred in the base of the skull. And I can't explain that. I don't understand how that happened. So the answer is yes, but it's extremely rare.
I think for the sacrum, it's probably still about a 20% risk of metastatic disease, even if overall, it's higher if you have a local recurrence, but unfortunately these tumors can recur after surgery that achieves local control of the primary tumor. And I continue to follow patients for life after treatment. I saw a patient recently, and this was actually very distressing, who had a lower sacral or coccygeal tumor removed 30 years ago, and then presented with chest wall pain, and he has metastatic chordoma. Primary tumor is controlled.
Wow.
Yeah, I've seen it, but it's uncommon.
And then if I could, Ed, I'd like to ask a question for myself, which may be naive, but in attending the research workshop the last couple of days, I think one thing that I took away from that experience was that some of the promising clinical trials require a combination of therapy between radiation and other therapy. And so I wonder, does the availability of that in the future for patients do anything to change the recommendation you provide now about whether or not or how much radiation they should receive now? And does it do anything about leaving tools in the arsenal 7 or 10 years from now if a combination therapy is required?
So in general, our recommendation is to really give the most optimal treatment up front the first time if possible. In our experience, if the patients are already recurrent after prior either lower dose radiation or prior surgery, it's much harder to salvage. You're limited by what additional dose you can give, and the recurrence can be it may no longer be localized. For example, if there's seeding of a surgically exposed cavity, such as, for example, like a chest wall implant, in the thoracotomy. So in general, we recommend doing as much as possible to optimize the first treatment. And it doesn't mean that there couldn't be, so for example, if someone needed emergent decompression surgery, but thoracic spine chordoma, but the thorax hasn't been exposed in any way, you can still give pre-op radiation and complete that surgery and then complete that radiation and still try to mitigate the potential risk for seeding. So as much as possible, we do recommend using the dose that is going to, that inadequate dose the first time.
It's a very good question because some people are left in a bit of a conundrum, like myself. For example, I have third recurrence skull base. I've had my complement of radiation in that area. I can't have more radiation. So I'm reduced to praying for a metastasis so that I can be irradiated so I can have the vaccine. Oddly,
So,
things are upside down.
maybe Dr. Patel wants to comment, but I was just going to say, from the perspective of a clinical trialist, our job is to fit into the standard of care that has already resulted in cures. It's not to override the standard of care. So our job is to prove that we're on the right track and then work backwards into the standard of care. And one could imagine that if in these scenarios where radiation is potentially required or potentially maybe a component of the treatment, that we want to build our rationale in a later stage to work backwards into that potentially even neoadjuvant or preoperative radiation therapy. And that's, I think we see some of those designs already in the trials that are coming up.
And the general route of development for improvement in therapy, and you've heard these terms, phase 1 trial, phase 2 trial, phase 3 trials. What it really means is that if we know from an animal model or cell line data that combining radiation therapy and immunotherapy could be beneficial, we've got to first test it in human beings in a phase 1 trial that proves just feasibility and tolerability. We got to figure out X dose of radiation plus Y dose of immunotherapy is safe enough to give it to human beings. Once we get to that stage, you get to the phase 2 setting where you start asking the question, well, in a cohort of patients, does it appear like the combination of the two things works better than what's the standard of care, which is good radiation alone? And if it makes it to that stage, then you get to the phase 3 setting where you would have to do a concurrent randomization where you take half the patients give radiation, other half radiation plus immunotherapy, and if the dual, the doublet is a winner, then that replaces the standard of care. And I think that's what you were asking, if I'm not mistaken, Andy, as to what happens to that doublet eventually. That is, if it proves itself that it's better than the current standard of care, then that becomes the new standard of care. So coming back to your point then, for a patient who is being treated up front or it's the first recurrence, they would get the newer standard of care as opposed to the older standard of care.
Right.
But I think the idea of reducing the radiation dose up front is something everyone here is trying to accomplish, but it's nowhere near yet, unfortunately. And so a lot of these trials have that in mind, but for the distant future. So I think everyone's on the same page with that, but right now, high-dose radiation is the standard of care and really should be given.
I just want to make one other comment on this point because it's a very good point. It's a problem we ran into a lot when we were trying to enroll patients on the vaccine trial that's already open. Unfortunately, we can't solve every problem all at once, but what we try to do is understand how does radiation achieve that effect, and then see if there are other therapies that we could give systemically, like a pill or other drug that achieve the same effect as radiation for someone who might have a recurrence and can't get radiation. So understanding the biology lets us then take that back to the mouse model or to the cell lines and say, can we do the same thing with something else that radiation does? And understanding it is a really critical component of being able to do that.
Okay, we better move through some people. Sir.
Okay, I just briefly wanted to explore chordoma from a very different perspective. And that is, I recently read the book Anti-Cancer, and I'm not sure how many of you are familiar with it, but the book really emphasized a holistic approach to trying to deal with what are the situations associated with cancer. In particular, it stresses psychological conditions, overall health in terms of exercise, and in particular nutrition. So for example, it talks about beneficial consequences of substances like turmeric, omega-3, green tea. At the same time, it talks about negative consequences, how these may actually feed cancers in terms of sugar and to some extent salt, and even to some extent wheat in terms of how it's consumed, contrasting typically Western and Eastern diets. So my question really in general here, is there any evidence related to chordoma that there are certain nutritional elements that are likely to be of benefit in dealing with chordoma or not, or other health conditions that have a particular positive or negative association?
Thank you. Who wants to take that?
I mean, I'll take a stab at it. I mean, yes, there is definitely evidence that all of those factors that you're talking about play a role in cancers. However, the role in individual cancers appears to be not the same for every intervention and every possible switch of diet. So there isn't one diet that treats all cancers, right? And actually, I would argue that it's very difficult to modify your diet in a way that is going to directly affect your cancer, because the effect that whatever that chemical might have or change might have has systemic effects, right? So it's very difficult to figure that out on a per patient and a per tumor basis. There's some really interesting work on diet as the way it can affect the microbiome, the bacteria that live in our gut, and that can have a direct effect on the immune therapies that are currently quite positive, and even on chemotherapies in some cancers, at least in mouse models. But to answer your question, being able to do that on a per patient basis and even on a per tumor basis is not yet something we can make recommendations on. However, I think the whole community of oncology researchers have started to take that question more seriously, and there is work going on in that field, but no, I don't think any of us can answer it today.
All right, thank you. We're going to keep it to one response so we can get through the last 6 people here, this side of the room.
Thank you. I have read that benign notochordal tumors found in the spine may indeed progress to chordoma. And if so, what is the frequency of that progression and the pattern of that progression?
Okay, I can look at that. So actually, I'm studying this at the moment. And
that's terrific.
And the reason I'm studying it is because we don't know the answer, but I think it's worthwhile. The question is, do benign notochordal tumors progress? There is evidence that they do. And I'll just give you some preliminary studies that we have. So I've looked at the whole MRIs of 200 people without just in the general population. Obviously they had something wrong with them, because otherwise they wouldn't have been having MRIs. And we found only 2 benign notochordal tumors in those 200 patients on the MRI. When I look at the population of our patients with chordoma, we find that about 15% of patients, 10 to 15% of patients with chordoma also have at least one benign notochordal tumor. So that incidence, and some of them have 2, so that would suggest that there is an association between benign notochordal tumors and chordoma. We're also trying to do the genetics now of patients with people only with benign notochordal tumor to see if they have the same genetic background as patients with chordoma. So if you know of anybody with just a benign notochordal tumor without a chordoma, if I could get your blood, it would be very helpful.
I'd be happy to help you.
Yeah. So I think that there is good evidence. Your other question is, do they progress? I suspect that the vast majority of patients with notochordal tumors do not progress. The vast majority. And the only reason, and we have very good evidence where some people have a big benign notochordal tumor and it sits there for years, and some people have evidence even after 20 years it's just sitting there. But there is also evidence that some do progress, but we cannot say which are likely to progress.
Thank you.
Okay.
Our imaging study showed a 5% risk of other notochordal lesions in patients who have chordomas. Ours are a little lower than that.
Right. And I've looked at the group with the Australians as well. We're doing multi-site, so we can include you, but it's somewhere between 5 and 15%.
Thank you. Stephen?
My question concerns clinical trials. With the amazing work that's being done, there are now various options in clinical trials. How does one go about determining if a clinical trial should be considered for an individual patient, and if so, which one of the clinical trials would be appropriate and when it should be considered?
So, since we don't have a clean winner in terms of what's the best systemic therapy when needed, I think a generic answer would be a clinical trial would be certainly preferred over any off-clinical trial treatment. Which one of the clinical trials would be the preferred one? There is no way to answer that. The definition of an experiment is that none of them have proven beyond a shadow of doubt that this is a clear winner. So I think the answer to that is that goes on availability, eligibility criteria, what makes sense, what's convenient, and so on and so forth. And then the difficult part of that question is, when should you institute the systemic therapy? And I think these are comments that you've heard throughout the meeting, that there are some tumors that may have a very indolent biology, meaning it's a very slow growing pattern with no symptoms. Those are patients where we go back to the Hippocratic Oath and say, above all, do no harm, because almost all of our treatment interventions do have some side effects. So there is a patient population where there are no symptoms and the rate of growth is not significant enough to be defined by the patient and the provider together. They need to be just monitored. On the other hand, if there is a reason to worry about any impending issues with surrounding structures, or there are symptoms, or the rate of growth is of concern, then I think treatment would take precedence over just a wait and watch approach.
So I think that's very helpful. So it's essentially a fair bit of guesswork as to which clinical trial one would go into if you had symptoms and they needed to be looked at.
I think there's enough breadth of the trials that are available now, this was probably not even true a year ago, that probably everyone, when they're evaluated, should be at least considered for clinical trial, just because the pace is quite quick. I think many probably wouldn't qualify or wouldn't be the best option for them, but it's reached the point now, and maybe Josh can comment on this, where I don't want to say what the Chordoma Foundation's recommendation is, but as physicians, I think we need to start considering those at every single step, including initial diagnosis. We may not recommend it, it may not end up being the course of action, but there is such a breadth now that it really needs to be considered at least at every step.
Thank you, that's very helpful.
Can I just say one thing really quick? As a medical advisory board, our job is to help make sure that there aren't conflicting clinical trials necessarily. So everything that's on the website from the foundation is intended to address specific questions sort of separately and not create conflicts where patients necessarily have to choose between trials. And that can be by location or by or the stage or the current setting of the disease. So there's an effort to try to make sure that it's a little easier for patients to understand which trial and when, but you still need advice from the doctor to help with that.
Thanks, Chris. This side.
My question is how to understand the considerations for whether to biopsy a tumor or not. And the context is it's a sacral tumor, but unreachable currently. So the current suggestion is we could get at it through the hip with a custom-made 20-centimeter needle. And based on how I've heard some people and some of the patients here talk about that, they said, ooh, you should think about whether or not you should biopsy this. So I'm just curious, we have a tumor, do we biopsy or not, and how would you think about it?
Well, I may and perhaps answer that is that if the patient is going to undergo a major surgical procedure or will receive a treatment that has significant side effects, I don't think it is wise to do that without establishing a diagnosis. And hence, categorically, any patient who is going to get treatment should be biopsied. There are special considerations when you are biopsying a lesion in the sacrum. There are certain routes that you should never consider. For example, biopsying the sacrum through the rectum is not advised, although it's commonly done for prostate tumors and other types of tumors that contaminates the rectum, potentially with tumor cells. Then you have to really remove it in order to attain negative margins, and it becomes a much more complicated procedure for the patient, and with loss of function and also compromising the rate of cure for that patient. And then the second no-no in the setting of sacral or spinal tumors for that matter, to get to the tumor through the abdomen or the chest. Sometimes we do for lesions in that location, and we would not advise that for tumors in that situation because, again, contamination risk of a large visceral organ, which now the tumor that is potentially curable becomes totally incurable. Having said that, and then there is the way to do the biopsy. In the old days, the biopsy needle was inserted to the tumor and pulled out, and that contaminated the tract. Many places now use what's called a dual needle technique, where there is an outer needle that is brought all the way down to the tumor and docked in position, and inner needle travels into the tumor. A trocar biopsy typically is done, and by doing so, you can protect the surrounding tissue from contamination. And finally, in some situations when we do a biopsy in the spine, we go through the pedicle of the vertebra in order to gain access to the tumor in the vertebral body itself through the posterior approach. And we sometimes place methacrylate or cement at the exit hole to minimize the seepage of the tumor into the soft tissue to avoid the contamination. So there are various strategies that one can use to optimize the results of the biopsy while not risking the surrounding normal tissue with contamination.
Can I add two very quick points to that? Is that not frequent, but we have seen patients sent to us to a chordoma center for what is thought radiographically to be a chordoma, and patient was recommended, sacrectomy. So, but then turn out to be giant cell tumor or some other type of tumor. So I think and the treatment course will be completely different, where sacrectomy and high dose radiation wouldn't be indicated. So that's important. And then the other thing is in terms of the path if the biopsy is done through a route that would be encompassed either by the radiation or surgery, then or certainly encompassed by the surgery, then it's not as much of a concern as far as seeding, because typically the radiation directions that we would choose, the beam directions, would typically cover the same areas as the biopsy. But if you have cross-compartment contamination, such as through the rectum or through the interior of the abdomen, it would be undesirable to try to sterilize such a big area. You would treat much more bowel, bladder, other organs that otherwise wouldn't necessarily need to be treated because they're not in the same compartment.
I'm going to just make one final comment related to the biopsies, which is, I think it's a very important topic, is that in sacral tumors, for example, we typically plan to excise the biopsy tract along with the tumor. And hence, whenever possible, we would like that biopsy to be as close to the midline as possible, because that minimizes the amount of normal tissue that we have to excise. If the biopsy is done far away from the midline, and then we have to then excise a fair amount of normal tissue to be able to get the tract, which then increases the morbidity of the surgery. So I think the planning of the biopsy is very critical, and typically we speak with the interventional radiologist who does these on a regular basis in terms of what we are trying to accomplish and communicate that very clearly to them.
And helpful to let your radiation oncologist know where that biopsy was done. If you can take a picture of it, make a note of where it was done, it is helpful. Or the image guide, the CT that was used for guiding the biopsy. Those are useful information that the radiation oncologist can incorporate into the treatment planning.
Okay, we're running
Thank you very much.
Yep, thank you. This side of the room, we'll just do these last 4 questions and then we have to eat.
I think mine will be quick. We have this expert recommendations for the detection and treatment of chordoma. It's a great book, pamphlet. But in there it says you do the MRIs for every 6 months for 5 years, and then if you don't have anything at that point, you could do it once a year for 15 years. What happens after 15 years? It stops there.
I would say for a skull base every 2 or 3 years after that, something like that.
Same thing.
Never stops. but
Never stops.
I'm still
the
following
period
some of Dr.
increases.
Sin's patients.
In spinal and sacral chordomas, usually I go to 2 yearly MRI scans, and after 10 years, every 4 or 5 years, but very frequently initially.
I'd like to get imaging every 2 or 3 years and at the same time catch up on everyone's kids and grandkids when they come in to see me.
It's true.
Social.
That's part of
The social indications. It's a difficult topic, though, right? So in my case, I was recurrence-free until year number 8. It's not an uncommon story. I could easily have been missed in that interval, if we'd backed off to an MRI every 2 to 3 years. And then it would have been a significantly larger size, potentially, right? So there's an argument to be made from, I've heard it in the community a few times that as you get further out from your tumor, you should increase the frequency of scanning.
And at least when you look at the recurrence curves, they seem to flatten out after 5 years, but they can continue to recur, unfortunately, quite late.
Okay, final one over on this side.
Sure. So whenever you're treating chordoma, you guys have recommended having a multidiscipline team across several different groups of doctors. And I happen to have that in the treatment of my chordoma, and a lot of very good doctors that I trust explicitly. And it's great when they all agree with each other as to what your treatment is supposed to be or what the path you should follow. But whenever they disagree with each other, or even worse, their treatment basically contradicts each other, how does the patient deal with that situation?
So I'll take this question. I think that the approach or the team can be administered in one place if you're lucky enough to have all of that concentrated in one place. In my practice, it was the same at Johns Hopkins, or now I'm at Brown, is that I have multiple specialists all around the country. So I typically, since proton beam facility is not available in many places, so if my patient is a good candidate for that, the images are shared with a radiation oncologist at a different institution. I get feedback and make that available to the patient, or sometimes we go locally, wherever is closest to the patient, to be able to get that. And I call Suresh not infrequently and ask him questions about a patient of mine whom I have concerns about the next steps, and get advice. And if I feel that the patient is going to be best served there, then I send the patient over there. So this is, in this day and age, I think that the multidisciplinary approach, don't think about it just being a locally available treatment option, but is available across the country or around the world for that matter.
But I think that's a really tough situation, but I think as a patient, you kind of have two options, neither which I don't know if they're right or not, but you can task your doctors to get together and figure out something they can agree on. That's a very reasonable thing to say to them. Say, look, you guys are giving me very different ideas here. Can you sit down and figure out what you think is the best course of action? Because I'm, obviously confused and conflicted by this. And if you really can't get that to happen, then perhaps a second opinion from another multidisciplinary team to try to get some guidance. And that's a very tough situation. But the best thing would be if your doctors who you trust can get together and really come up with a treatment plan that they can all get on board with.
So one quick thing I will add is, I think what that tells you is that there is no clear winner, there is no clear-cut answer, right? There are pros and cons of both options. If the surgeon's recommending surgery, or sometimes vice versa, surgeon's recommending radiation and radiation therapist is recommending surgery, there are pros and cons. And I think at the end of the day, what ends up happening is that you just have to grill them enough so you make your own list of what are the positives, what are the negatives. And at the end of the day, you are on the hot seat and you absolutely have a say. And it's a matter of weighing the risks and benefits and coming up with what seems to be a rational, reasonable option that's acceptable to you. May not be acceptable to the next person, but at the end of the day, that's personalized medicine.
Yeah,
Very good point.
Thank you.
My question has to do with medical IDs, the alert bracelets and necklaces. And if you recommend your patients having them, and if you do, what information they should have on them. Specifically, in my case, it's like a clival chordoma. Is there anything that, if he was in an accident, that the treating physicians should know, so they either do or do not do certain things?
I mean, we do recommend to our patients who have had extensive clival surgery that they have either on their phone, which is one of the best ways now, or a bracelet that does say no nasal instrumentation, because a common thing that people do in accident is shove things in your nose, and that theoretically could be a problem. If it's well healed and scarred, it probably won't be, but it's something enough that it probably should be on a bracelet. I have a patient who got an entire forearm tattoo that said that. I'm not sure that that's necessary. I think it's
There's a booth, we have a booth set up outside. Shannon's running the tattoo parlor.
It's pretty, yeah. And the blood draws for Dr. Flanagan will be right next to it, I think. So.
Yeah.
But I think that's the one situation where it's wise to have that.
Good question.
Hi.
Last one.
We've got a 7-year-old daughter who has clival chordoma. She had 3 operations in Australia, and then we were lucky enough to come to Boston to see Dr. Leet for proton beam radiation. From my accent, you can tell I'm an Aussie, and we are back in Australia now. Our radiation oncology team, because we don't have proton beam radiation, is photon-based. So the team we see there, how can we feel confident that they're giving us the right follow-up for our daughter? Would they know the right things to be looking for post-proton beam radiation treatment? We don't have a lot of experience with chordoma there, so we'd just like to know if the radiation oncology team, even though they're photon-based, would they know the right things to be looking for our daughter?
They certainly would be able to interpret the radiation plan, which could be shared with them, and you probably want to be followed by someone who's seen chordomas before, and I think the follow-up would be pretty similar, and that clinician could certainly contact Dr. Leach.
Dr. Leap is looking over her MRIs anyway, but we're just wondering, the MRIs done in Australia, will the team there reading them know as well the right things?
I think it is important to establish a care relationship with a local physician as well, because if she has an acute event, you're going to want someone who knows her history.
Yeah, okay, thanks.
Okay, thank you. A huge round of applause for our panel. Thank you, everyone, for taking time out of your very busy schedules to be here. That's awesome. Thank you so much.